Thank you very much for having me. I certainly appreciate the opportunity to come. I've learned a lot since I've been here just in a few short days. I love the cultural differences and especially the wording and some of the habits I've seen has been very, very nice. So thank you for having me. Make sure I've got this right. As we talk a little bit about today, I want to try and see if I can make you think a little bit differently about a problem that perhaps you believe that you've thought about quite a bit, but hopefully try and convince you that there may be some additional things to consider. I do have to give you some disclosures. The long and short of it is there's several committees, grants, things like that. This is not something that I'm going to try and give you non-evidence-based. These are evidence-based findings. They are not things that will be made money on. I don't have anything to disclose or otherwise. To start, we know that smoking is the largest preventable risk factor associated with the development of cancer. Several different cancers, this has been well known. There's about 7,000 compounds in cigarette smoke. Actually, there's 65 known carcinogens. And there's a lot of stuff that's been added to try and increase addiction, specifically to try and increase absorption, addiction, flavoring, and so forth. So you can add a lot of things to tobacco. You light it on fire, that won't be good. About 15 years ago, I actually downloaded additives to cigarettes from a website. There's a tobacco website. There's a lot of interesting things that could be added here. I've highlighted a few examples in bold: acetic acid, ammonia, apple juice concentrate. And then if you want to know what the entire list of things that could be added, here's the list of chemicals. And this isn't rocket surgery. If you light all this on fire and you inhale it, it's going to be bad for you. And so we've done a lot to know that smoking increases the risk of developing cancer. You might ask yourself, why do we do this? Well, this is a map of the United States to show geographic distributions that came out from 2012 Behavioral Risk Factor Survey. And I don't have the data actually for Australia right now, but there's a huge difference on regional use patterns. This is not something that's one size fits all. There are cultural differences also in the United States for tobacco patterns. And perhaps the most common theme is that you have a big distribution of tobacco use, particularly in the United States, in a certain region, the Southeast and Appalachian areas. Now, I don't know if I have a pointer here, but the brown state you see right there in the middle is Kentucky. I always joke around with people that there's a couple of little white dots here in Kentucky that look like maybe there's not tobacco. I always joke that that's just an area where they didn't go in to ask any questions. And this is important because with regards to rural access and the ability to identify use patterns, risk, and outcomes, you're limited in part by the ability to effectively communicate with people in different regions. We have the exact same issues throughout the United States. However, if you wonder why it is that people smoke, if your mom smokes, your dad smokes, your brother, sister smoke, there's a good chance you're going to smoke. Now, just for disclosure, to let you know, this is actually my son. He's now 13. We penciled the stogie in, the cigar right there. He still has his little mom tattoo right there. But it's a hard habit to break. And when you look at addressing tobacco use, particularly in cancer patients, you got to remember the overwhelming majority of these patients started smoking when they were teenagers, 12, 14, 16, certainly before 18 years old, almost across the board. This is an imprinting habit that is exceptionally hard to break. And this is something that even after 20 years of cessation, you can walk through a puff of smoke, you'll feel the buzz, you'll want to smoke again. So this is a huge imprinting behavior that's particularly hard to change around the time of certainly getting cancer. Now, you might ask yourself, why do we care about cancer patients anyway with regards to smoking? We can treat them and do just fine. Well, as David said earlier, in 2014, the Surgeon General's report was the first one to actually try and evaluate what were the effects of tobacco use on cancer treatment outcomes. And this was actually about 1,800 man-hours of work by me for what turned out to be 5 pages in this report. So if you get called by the Surgeon General's committee to write something, you're going to spend more time than you might originally think. However, this was nice because this really reviewed about everything between 1990 and 2012. There's about 450 studies that went into this, and of these studies really tried to focus on what were the effects of tobacco on survival, treatment outcomes, recurrence, and things like that. Now, I spent a lot of time putting this together, but this was really, the data that was put together went through 15 levels of review. I don't know if you've heard of the word bureaucracy. I think I've heard of that once or twice here in Australia, but there was a huge number of people that reviewed the findings. So the conclusions, technically, we didn't know what they were going to be until the final report came out. The conclusions that came out were striking. The evidence was sufficient to demonstrate that smoking by cancer patients and survivors caused adverse outcomes. It specifically increased overall mortality and cancer-related mortality. It increased the risk of getting a second primary cancer, and there were very strong associations between smoking and cancer treatment toxicity. The magnitude of these effects was substantial. If you take a look here, this is actually kind of a summary of the median effects of smoking, positive and negative studies across all cancer disease sites and treatments. With regards to overall mortality, current smoking increased the risk across disease sites and treatments by about 51%. Cancer-related mortality, 61%. And you can see former smoking, quitting smoking in the past, those risks were substantially reduced or non-significant whatsoever. So current smoking was strongly associated with adverse outcomes. And you might think to yourself, well, this is a head, neck, or a lung cancer problem. Well, if you go through and you try and actually identify the studies that have looked across a spectrum of cancers, this actually is a bar graph to kind of give you an idea based on, and the red actually shows, hopefully those of you who are red-green colorblind, the ones on the left. The red bars indicate the number of studies that showed significant negative associations between tobacco use and at least one outcome, survival, toxicity, recurrence, whatever it may be. You can see across head, neck, lung, breast, prostate, hematologic, GU, GI. This isn't a head, neck, and lung cancer problem. This is a cancer problem. The effects are true across disease sites and treatments, and so you can really use this as a way to try and address a variable that's important within reason pretty much across cancer as a whole. I like to use prostate cancer as an example. What do most prostate cancer patients die of? Anyone? I guess I shouldn't wait for an answer, but not prostate cancer. They die of something other than prostate cancer. And this is actually a nice study that highlights some of the significance of smoking in prostate cancer patients. You can see here in these 1,300 patients, about 10%, or actually 8.7%, died of prostate cancer. 90% have died of something else. And you can see the risk ratios for current smoking on those risks outside of prostate cancer were enormous. And so smoking, I like to give an example, prostate and breast cancer, which now also has a very high cure rate. These are patients that may benefit even more than lung or head and neck cancer patients simply because their survival and cure rates are so high. We're doing a lot of work right now to try and specifically summarize studies that have looked at the effects of tobacco cessation in cancer patients. And we have a number of studies. This will be coming out shortly. This is a preview of parts of it. But you can see, are there benefits to cessation? Well, there's a lot of different things that have been looked at: overall survival, recurrence, quality of life, toxicity, things like that. This is the summary just for overall mortality. And just so that you can see a consistent pattern of significant reductions in mortality in people who quit smoking. So there are benefits to cessation. It makes a difference. Now you might think to yourself, clinical trials are designed to try and advance knowledge. Primary objectives of clinical trials are what? Overall mortality, cancer-related mortality, progression-free survival, toxicity. Those are the primary secondary objectives of virtually all clinical cooperative group trials, or clinical trials in general. We took a look at this a few years ago to try and evaluate how is tobacco being evaluated in clinical trials, and we showed here that 71% of cooperative group clinical trials, at least in the United States, didn't assess tobacco whatsoever. This was received with mixed findings. Some people were excited to show this, and some people were pretty not excited to see this. This means that we're taking our most advanced cancer treatments, the next generation of what we're going to do to try and improve outcomes, and we're not assessing a known variable that affects overall survival, cancer-related survival, toxicity from cancer treatment. And so eliminating this variable could significantly skew or bias results in clinical trial design. So then we went back and said, well, what happens with regards to oncologists and practicing physicians? And we sent out 3 different surveys. The first 2 have been published. The third one hasn't been published yet. But we actually looked to find out, what do oncologists do about tobacco use? And you can see here that about 90% along the top ask about tobacco use, and then there in the middle, about 80% advise patients to quit. But physicians report less than 40% actually helping patients quit. And if you go to patient surveys, you'll see that it's actually cut in half. About 20% provide cessation support to try and help people quit. So we went back and said, well, what can we do about this? We looked at the barriers associated with this. We looked at a whole variety of different barriers. And interestingly enough, these surveys, 90% of respondents said that they thought tobacco caused adverse outcomes, and that tobacco cessation should be a standard part of cancer care. So they were motivated physicians, but still demonstrated those practice patterns. Here we went back and tried to evaluate specific barriers. This is too small a typing. I know there's too many ratios. It's actually just a copy and paste right out of our paper. You can actually see the pattern where specifically time, resources, and education were the dominant barriers to providing cessation support. So now we have a target, things we might be able to do to try and improve providing cessation support for cancer patients. So we did. This was a follow-up survey we sent out to NCI-designated cancer centers, which we presented in an abstract that's not published yet. And this was a funny slide. If you look at this, we asked oncologists, we said, hey, listen, we're going to give you the option to try and provide cessation support. How do you want to do this? Who do you want to provide this? And you can see some said primary care, some said nurse practitioners. I just want you to try and focus on that really skinny red part. 1% said they wanted to provide cessation support themselves. 50% said, I really don't care who does it, just not me. If I try and get my oncologist to provide cessation support, I'm not sure how well it's going to happen. I'm not saying don't educate or advocate or anything like that. But what I'm getting at is that it may be difficult to educate physicians and expect them to provide the cessation support necessary to get people to quit. We went back and asked them about education and cessation support. Only 10% said they had adequate training. And again, this goes back. Look at that green bar and a second one from the top. 55% said, we want you to educate someone, just not me. Anybody else in clinic, just not me, on how to provide cessation support. I call this a disservice in cancer care. There's a little bit of irony or maybe cynicism in this talk. We're not satisfied until you're not satisfied. We can't continue to realize these deficits if the effects of tobacco are so robust and cause so many problems in our cancer patients. Well, what can we do about this? Well, we went back, and I'm a radiation oncologist. I am not a cessation person. I am not an epidemiologist, although I have some epidemiology. I'm not a behavioral economist. I am a radiation oncologist with a PhD in toxicology. I'm an engineer by heart. If we're going to do something, I want to do it efficiently and effectively in a manner that actually produces some kind of results. So how do we try and address this in a manner that would translate effectively but efficiently? Well, we designed a program at Roswell Park, which is where I was before I am now, which was a phone-based cessation program that used an automated tobacco cessation approach, where all patients were screened for tobacco use using a structured questionnaire, and the electronic medical record were automatically referred to a cessation program that proactively reached out to call patients. And this was the basic algorithm, but basically, if you screened positive, you were automatically referred, and then you went into a follow-up if you didn't screen positive the first time. From this, 12,000 patients in our screening, 2,700 patients referred to our cessation program, we evaluated the effectiveness of contact and intervention. And you can see here, we had 1.5 cessation experts to try and provide cessation support. So every day we went from the top down and we started trying to call patients, and this really divided it into two different groups. One group, we had 1,300 patients where we called them at least 5 times, and we were able to reach 81% of them. You can see that circled in blue. Of the people we contacted, only 3% refused cessation support. That means I've got their attention. 3% said, I don't want to participate. It doesn't mean they quit. It just means now I've got access. I've got their attention. I have the opportunity to try and intervene. If you look up at the top right, you're going to see that we also sent these big, thick, fat cat mailings. Fat cat is a great term in the United States. I haven't heard that here. It probably has an interesting pronunciation here. Big, thick, expensive mailings. Tobacco's bad. Give us a call. We want to help you quit. Out of 1,381 patients, 16 patients called our program. 16. I don't find that particularly appealing. So I don't send mailings anymore. And this is the biggest reason why. Now, I told you that efficiency was a big deal. Well, we went back and said, we built the cessation program from scratch. There was 25 people in the room that we started this process with, a lot of tobacco cessation experts. They wanted 37 questions on a screening questionnaire. I said, guys, you're nuts. This is never going to work. But it was a team. We tried to roll it out. Nursing said, we won't do this. I said, okay, let's take it back. I didn't think it'd work. Let's take it back. We modified it and got it down to about 20 questions. Nursing again said this is quite a bit to try and ask all the time, because we tried to ask this every day. Every time a person came in for cancer treatment, there were people that said, we need to ask this every time. I said, we can't do this as often, but let's give it a try. After 2 weeks, nursing came back again and said, we can't do this, change it or it's gone. And so we went to every 2 weeks. There's 2 important findings that came out of this. First, 99% of patients we identified with 3 questions. And as a matter of fact, one question in particular, how long has it been since you smoked a cigarette, even a single puff, is probably the highest yield single question you can ask. It identifies probably 95% of patients. That gives me efficiency. Then we went back and looked and said, how often do we have to ask this question? And in 428 patients, 428 smoking patients referred to our cessation program, if we ask questions no more frequently than once a month, we delayed cessation referrals in less than 1% of people who needed support. That's efficiency. And unfortunately, we're the only people that have looked at this in cancer, but it shows that it's possible to try and do this and not be obtrusive. Then we went back and said, well, we got a cessation program. This is great and wonderful. Does it make any difference? We went back and looked at our people in our program who are current smokers, try and find out if we made any kind of difference. In our lung cancer patients who were smoking, came to our program and quit, we reduced mortality by 44%. Lung cancer patients quit smoking, 44% reduction in mortality. There's nothing I can add to lung cancer treatment to reduce mortality by 44% to whatever the frontline treatment's going to be. Now, this isn't the definitive answer. This is a strong signal. A phone-based, efficient cessation program that gets people to quit smoking can manifest in a clinically meaningful outcome. We showed the same thing for the National Lung Cancer Screening Trial. As a matter of fact, if people quit smoking for 7 years, they equated to the benefit of CT screening. Anything beyond 7 years, their survival was even better than CT screening. It's amazing how easy for a group of people to work together when they had no idea where they're going. If we've been trying to figure out how to improve our cancer treatment outcomes and ignore cessation, we may not be making nearly as much progress as we think we are. What can we try and do to make this better? Well, we do have guidelines. This is actually in DaVita. There's a 5As, which is a standard approach. It's going to be in DaVita again in the upcoming issue. So you have the opportunity to actually read about cessation if you want to some significant degree. We also, there we go, now have the NCCN Guidelines. And actually, I've heard that NCCN Guidelines are reasonably fairly widely used here. This is great. We, in 2015, NCCN Guidelines advocate for providing cessation support for cancer patients as a whole. And there's guidelines in there to show you how to do it or to talk about it. And I'm going to get back to this in just a minute because remember I showed you that oncologists may not be the optimal group to provide the cessation support, but the guidelines are here. You have the evidence base. You can advocate for this. It's bad for treatment, and we have cessation support we need to provide using guidelines. You have an evidence base to justify development of these programs and approaches. We work with the NCI and AACR for years to try and develop standardized questions. There was actually an abstract I haven't written and I need to actually publish because we went back to Surgeon General's report and looked at the variety of ways that tobacco was defined. There were 75 different ways that current tobacco use was defined by these studies. It's all over the board, and so the development of standardized structured questions gave us the ability to define it very well in an efficient manner, but also be able to compare it across different groups, different studies, and so forth. The common core questions are here from the NCI and ACR task group, and this goes back. If you look there at the bottom, how long has it been since you smoked a cigarette, even a single puff or 1 or 2 puffs? You have an annotated response, less than 1 day, 1 to 7, 7 to 30 days. People who use tobacco in the past 30 days need cessation support, and that's in the NCCN guidelines. So as silly as it sounds, over the past 10 years, we've actually started really gaining consensus across guidelines, across questions, and across clinical effectiveness. Now, this is an accident study. I started a study in head and neck cancer patients where we came in and said, we're going to treat you with radiation chemotherapy. We're going to ask you about tobacco use every week during treatment. We're going to take blood every week during treatment, and we're going to measure tobacco in your blood. Do you want to participate or not? And they said, yes. We didn't pay them anything. You would think if a person knew we were going to measure in their blood, they'd tell us accurately what was happening. But you'll see this little red line at the bottom. Every week, week after week, there's a group of people who will not tell you the truth. I know, it's hard to believe. Every week. And we've seen the same thing in other disease sites, breast, prostate, lung, and other studies have shown the same thing. Long and short of it is that there is an opportunity to provide biochemical confirmation for people who are very interested in this, and there's a value because about 30% of people who are 30% of cancer patients who smoke will misrepresent tobacco use. So that's not something that I'm saying you have to do, but if you do want to get an accurate assessment, biochemical confirmation can assist quite a bit. I refinanced our house a few years ago, and I was put on one of these email lists. I don't know exactly, but I get these kind of offers all the time. I'm Doctor, can't pronounce the name, and I have a bunch of money. Just give me your account and your social security number. We'll send it to you. It sounds like a great idea, but maybe we haven't really thought about all the aspects of trying to participate in it, right? There's something you need to think about, and unfortunately, we haven't done it a good job of. Biology. The biologic effects of tobacco lead, obviously, to developing cancer. If you think that once you get cancer, it turns off the effects of tobacco, I'm going to argue that you're probably wrong. But unfortunately, we have not done a good job of identifying the biologic effects of tobacco and how we might be able to use this to improve our cancer treatment approaches. We reviewed this a few years ago and found about 34 studies that actually looked at the effects of tobacco in cancer cells. So we started playing with this for a while. And this is all unpublished data. We've been developing this model for several years and actually working on biologic outcomes. So you want to talk about current, recent data. This is as current as it will get. And the entire audience, I just want you to focus on those two circles in the middle bottom of the page. Don't worry about the rest. In biologic systems, smoking, chronic cigarette smoke exposure decreases the effectiveness of radiation, chemotherapy, 5 different chemotherapeutic agents, 8 different cancer cell lines very consistently. And if you want to know the significance, those two circles at the bottom are called clonogenic survival or colony survival assays. And what it is that you grow cells up and then you stain them purple, and the purple cells are the ones that are still left. And you can see there at the bottom, the radiation is the circle on the top. There's not that many cells left when we treat them with radiation. But when I add cigarette smoke to radiation, the one below that is the effect. Can you see a difference? Is this what we're doing if we're treating people with radiation and they're smoking? Do we leave this behind? This is the kind of question you need to ask yourself. And remember, do I want to leave this behind if I'm going to treat someone with radiation and chemotherapy? These are the types of things that we haven't thought about as well. And we started digging into it further. We actually looked at some of the reversible effects. We did xenografts, we did tissue specimens. How many people here are pathologists? Good choice. Yeah. I guess if I'm being recorded, I shouldn't say that, right? What we're looking for is black or brown nuclei here. And this is a lung cancer xenograph, which means lung cancer. Took it out, and we looked at something called HIF-1 alpha. And there's a bunch of things we looked at, but HIF-1 alpha is striking. This shows essentially no dark nuclei. But what happens if we activate the nicotinic receptor? Can anyone see a difference here? This is a huge difference. Not only that, but look at the morphologic pattern you have here. The whole tumor doesn't necessarily respond the same way. You have this characteristic tumor stromal interface where you have activation of HIF-1 alpha in the expression, in the activation of nicotinic receptors. And then what's really interesting is if you take it away for 3 days, look what happens. It goes back. It's reversible. The biologic effects are reversible. If we're not assessing tobacco in our clinical trials design, and there's potential interactions between biology and protein expression, and we're randomizing our studies to treatment based on protein expression, are we missing the boat? Is this something that's going to add significant bias to it? We already know it makes a difference for outcomes. We need to start thinking about tobacco not as just a stigma and a behavioral thing, but it is a biological, behavioral, societal, clinical, and I'm going to offer one more thing, cost-determined outcome. We looked at this a little further, as a matter of fact, and we found, this is, you're going to notice here, this is highly unlabeled. We found a germline polymorphism that about 50% of the people have, about 50% don't. And if you have this, you drive a dominant tumor pathway in the presence of cigarette smoke, not by itself. In the presence of cigarette smoke, you drive a dominant tumor pathway, and you can use a targeted therapeutic to prevent the effects of cigarette smoke, at least in cell cultures. I mean, this is highly preliminary. But how many of you have ever thought about the possibility of using a targeted therapeutic to improve outcomes in patients who smoke at time of diagnosis? And if you haven't thought about that, why haven't you thought about that? If this makes such a big difference, if it decreases the effectiveness of cancer treatment reasonably ubiquitously, if we figure out how that works, we may actually make cancer treatment in general better, not just for smokers. You know what? Today, the only thing I'll say here is that we look back to this polymorphism, and at the bottom, PD-L1 in immunotherapy is the new thing. We're affecting PD-L1 expression based on this polymorphism. Why are we running expensive trials and looking at extremely significant outcomes in the absence of cigarette smoke? It doesn't make sense to me. It's something that needs to change. Hypothetically, this could change how we look at it. If you have a person who's a current smoker, you want to get them into a cessation program. These targeted things are not so that they can keep smoking. This just try and increase the effectiveness of cancer treatment. But what if we had biomarkers to try and help guide treatment further, either from cessation therapies, targeted therapeutics, or otherwise? So we've heard about staging for cancers. This is my thought process, so there's no evidence base behind this. But I'm going to convert tobacco into stage 1, 2, 3, and 4. Stage 1 is clear evidence that there's an effect. Stage 2 is seeing if we can actually make things better. We've done that. We've got it. The evidence is there. We're at stage 3 right now. How do we try and implement change so that we can manifest and increase cessation activities? What are the programs that deliver this very well? Stage 4 goes back to that biology. What treatments, what cancer treatments are better in people who smoke at the time of diagnosis? What types of targeted therapeutics have we not even thought about to possibly change outcomes? We've run, there's a group of us, again, you're talking about new evidence, this isn't published yet either. There's a group of us who have been working on the cost implications of failure of first-line cancer treatment in patients who smoke. And this basically shows attributable failures per 1,000 patients based on the prevalence of smoking, the baseline failure rates, risk ratios for the effects of cigarette smoke. And the long and short of it is that in the United States, we have 1.6 million cancer patients diagnosed every year. If we have a baseline failure rate of 30%, which is conservative, and we have a smoking risk that's 1.6 or 60%, which came out of the Surgeon General's report, which again is conservative. That's cancer-related mortality. First-line therapy failure is going to be higher than that. If that's the case, if you look, and again, this is new as could be, the cost of treatment being $10, $50, $100, $250,000 for the cost if you fail first-line therapy. Here you can see those two red numbers at $50 and $100,000, which is exceptionally justifiable in the United States. We have $1.7 to $3.4 billion a year in cost associated with treating first-line cancer treatment failure because of smoking. Now, I was on a plane, not sleeping as well as I could, but I did spend time trying to figure out what the implications were here in New South Wales. Using the same modeling, if you have $10,000 per treatment failure, it's about $8 million of cost. If it's $50,000, which is I think probably where it is, although I couldn't really get that information, you're talking about $40 million of additional costs. These are from conservative estimates of just first-line treatment failure, not including overall mortality, toxicity, hospitalizations, and so forth. This is something we're not going to spend a whole lot of time on. This will be something we can ask about, but when you think about designing a cessation approach, you need to be able to sell it well enough. You need to think about institutional buy-in, you need to think about the opportunity to get people involved, and you got to have sustainability. And how you're going to deliver cessation support is very important. However, overall, it doesn't have to be that hard. And for a large or a small center, most of the aspects, including a standardized screening, referral, pharmacotherapy, counseling, referral to a quit line, and buy-in can happen in any place. The real aspects are whether or not you have cessation specialists or you provide it in the clinic or by phone. These types of things are a little bit nuanced, but really a lot can be consistently thought of and delivered independent of institution size or clinic size. Right now in the U.S., and I think here, we are trying to figure out the diagnostic and treatment timeline, where you go from an area of concern to diagnosis to consultation to treatment to follow-up. And our goal is to shorten the time between the area of concern and treatment. And that's what everyone's trying to focus on. Right now, we have two primary groups that work on this. Primary care works on the early end before diagnosis or before the oncology consultation. There's a little bit of mix. Then you got oncology care that unfortunately, there's a nice blue arrow to try and get things back to primary care, but doesn't happen very often. Think about how you can engage tobacco cessation across this timeline. The reason this is such a big deal is because the longer you quit smoking, the better your therapeutic response is going to be. If you can quit for a month, it's going to be better than if you quit for a day. If you quit for 2 months, it'll be better than probably a month. If you can take advantage of this timeline of concern to diagnosis to treatment and provide cessation support, particularly in that timeline in preparation for cancer treatment, that's our best chance to try and improve clinical outcomes. I'm going to advocate, in my experience, to think about an ask, advise, and refer, or an ask, advise, and connect model, which is, for me, essentially the same thing. Asking, you identify tobacco use with structured assessments. Advising, this is where clinicians across the entire spectrum of care need to have the same message. Every clinician should say, hey, listen, tobacco is bad, and your cancer treatment, is going to, the best chance of you getting a successful cancer treatment is to try and quit smoking. That's what you can do to try and make things better. If you don't know how to quit, that's fine. Say, I have no idea how you're going to quit, but we got a cessation program to help you quit. Or we're going to give you access to this. I have no idea how you're going to quit. We're going to use this program. Ask them how they're doing. How are you doing with your quitting? Or how are you doing with smoking? And if they've reduced, say, great job. Don't criticize them for continuing to smoke. Remember, this is a systemic addiction that started when they were 14 years old and they got cancer. It is hard. Congratulate progress. Connect them to a cessation support. Additional considerations to think about, okay? And this is something that you have to buy into. I know how we are, and I'm happy to help with these types of things. How do you synergize a research message with clinical delivery? There are huge research questions coupled with clinical effectiveness with regards to tobacco and cancer patients. Consistent documentation and assessment, efficiency, try and coordinate across lots of different centers, and then message with a clear vision. Tobacco's bad. This is something you can do to try and make your cancer treatment better, and we are in this together. And I like to emphasize that we are in this together. Get your clinic to buy in, your receptionists, your technicians, all nurses, physicians, administrators, buy in. This needs to be updated, but I want you to realize that when you think about tobacco in cancer patients, you've got the biologic effects, the clinical effects, tobacco cessation. I used to have population, but really tobacco cessation-related things. And then we are being pushed more and more into the cost variables associated with this. The facets associated with tobacco use in cancer patients are significant. Don't just think of it as smoking, they don't care, we're not going to provide cessation support. Right now, this is possibly one of the best opportunities we have to improve cancer treatment as a whole. It's difficult to comprehend how insane some people can be, especially when you're insane. I agree. We're not training people as well. We're not thinking about this the same way. We're not getting our residents or medical students thinking the same way. We've got to think a little different. And I hope you walk out of today thinking just a little different, thinking this is something that we need to do and this is something that's important. This slide will never go away. I try to, my favorite thing is that top left, statistics show that teen pregnancy drops off significantly after age 25. Yeah, I agree. I don't need to know anything about that study. It's 100% right? Sometimes the question in front of us is very, very straightforward and obvious. This is one of them. Tobacco doesn't stop at a cancer diagnosis. It continues after. The question is, what can we do to address this to improve our therapeutic outcomes for cancer patients? And this is my talk for the day. I think I can take questions. Is that right?
You certainly can.
All right. So thank you for having me.
Ladies and gentlemen, I was so busy tweeting there was a slight pause. That was an absolutely gripping presentation, and we do have time for questions or comments from the floor. So wave at me and I come to you with surprising speed. And someone called Laura is going to come out the front, and she's getting the app questions. And there she is. You wave at me when you've got an app question. Where was the gentleman who just waved? Thank you. Do you mind just introducing yourself?
Len Thomas is my name. I work with holistic health. The problem I find starts within the saliva glands, and we've got to try and get the changes starting from there, because it's coming into the saliva glands. Also, when I'm working with people, I can actually tell whether they're fair dinkum about giving up smoking or not, because I can smell it. Mm-hmm. And it stinks. On top of that, I gave up smoking 30 years ago, 80 a day.
Excuse me, but at a conference like this, there is meant to be spontaneous applause.
Yeah, straight dead cold. Didn't go through any therapies or anything. I suppose I had it within myself to just give it up. And never had another smoke since. But I smell them.
Thank you.
Thank you so much. Could I just ask you, what do we know about different variable responses to different strategies? Because we're encouraging people for referral. Is it common for people to be able to stop completely alone? Others need support. Do we have any evidence about that?
Oh yes, this is actually, we've talked about this a lot the past couple days. We do an exceptionally poor job providing cessation support for cancer patients as a planet. In general, 5, maybe 10% of patients who smoke at the time of diagnosis get access to cessation support. And we've got some studies that report on those 2 or 3 or 5 or 8% of patients. I don't have the information on the other 90%. Give me the information on the other 90%. What I mean by that is that in general, some people will quit on their own. Some people need a little bit of support and they'll quit. Some people need a lot of support to quit, and some people won't quit, and you can't do anything about it. I mean, they're just going to keep going. And we've seen this in clinical practice. These are not, rocket surgery ideas. This we see. The access to cessation support needs to be provided for everyone. From this, we will start to learn what groups of patients really respond well to minimal intervention, who responds very well to phone-based support, or maybe an app, or intensive support, really in a clinic with biochemical confirmations. We don't have good distributions on the overwhelming majority of patients who smoke at the time of diagnosis. So there is a graded response. We've seen that a lot ourselves. We have a fairly universal automated program that we've quite a bit of experience with. What we need to do is get everyone involved and start to tease out what those graded responses are based on what the intervention, the optimal intervention would be.
Thank you. Another question, thanks. And if people could just introduce themselves and I'll hold the mic.
Yeah, Philip Beale, I'm the Director of Cancer Services at Sydney Local Health District. I'd be interested in terms of what has happened in the US in terms of with this data coming out over time and what has been the way that clinical, cancer centres have approach this versus maybe the other models whereby people are seen in the offices of the oncologists, for example, and how they've sort of banded together to work out a pathway for that service. And have you seen that happening actively?
So I actually tried to help a lot of places start programs, and some have been successful and some of them have not. I would say that buy-in at the highest level is very important, particularly in the United States. If the person who writes the checks buys into it, you're going to have a sustainable approach. Having said that, this is kind of strange. I realized this a couple years ago. In the past 10 years, we've changed the approach to looking at tobacco and cancer patients really as a whole. We have the Surgeon General's report. We have opt-out type programs we've developed that improve survival. We started some statewide initiatives. We've got NCI that really bought into this. They've started a new funding mechanism for this. We got the NCCN Guidelines that are dealing with this now. And what I'm getting at is that we've changed the perception of practice. Now a lot of places are starting to try and develop them. Rarely do you actually see the translation of something into practice in a career, and in 2, over a relatively short period of time of 10 years. The individualized practice is exceptionally important. I don't have 2 places that do the same thing, and it's because nursing, intake, scheduling, billing, equity with regards to philanthropic or charitable types of donations could or could not be important. The specifics of how patients come through a clinic and the resources available is absolutely critical to consider in how you develop and maintain a cessation approach. In reality right now, the most important thing is to get everyone in. Once we get everyone in, get some researchers who know what they're doing to look at the data and find out what groups of patients respond really well and where are the gaps. That'll come a couple years after you get everyone in, and we're doing that ourselves. But the goal will be to try and start providing evidence-based care across the spectrum, and it will vary by institution.
I'll hold it. Do you want to just introduce yourself? I hold it, yeah.
Okay. My name is David Sinnott, and in this environment I'm a layman, I'm a consumer representative. And I have a question rather than a comment, please. In any cessation program, have you included a sports medico, a physiotherapist, anybody who could talk to, this goes right back to primary health care, someone who can say your physical performance will improve if you give up smoking. So whatever that person's ambitions are, particularly if they play a sport, active, right back to primary healthcare, do you actually address how giving up smoking will improve their physical performance?
We do. So, I want to make sure I understand right. So, did we involve someone for performance in the start? We involved patients in the development of these initiatives, but they were cancer patients, not necessarily athletes or performance. However, the performance has been addressed a lot of times in the past. We used that data from the past, so improved breathing, improved heart rate, reduced blood pressure, increased oxygenation, more energy. Those types of things we do use in our cessation discussions. And so yes, we do that secondarily. We didn't approach a patient, we didn't approach anyone for the development of our cessation programs related to performance. We did with regards to cancer care. And so hopefully does that answer your question well enough? All right.
Can I just ask you, I'll come back to this gentleman, I'll come back here in a second, because I had a follow-up too.
Oh, the only question is, did it work?
It really motivates some people. Some people it doesn't motivate as much. I think it goes back to a little bit of an individual. I hate to say it, but I don't smoke, but I got some other things I got to work on that are not great health conditions, right? So, some people's receptiveness differs. And I'll use this as an example. A lot of times people ask me about metastatic cancer patients. Should we get people who we're not going to cure cancer to quit smoking? I use this as an example because we know that smoking will decrease the chance of hospitalization and toxicity. If you let a physician decide, hey, they got metastatic cancer, I'm not going to provide cessation support, I disagree. Let the patient decide. Say, listen, you know what, I don't know if I'm going to cure your cancer, but if I keep you out of the hospital, is that worthwhile? And it goes back to kind of a performance and letting someone decide, do I want to try and have the opportunity to go to the hospital less often by quitting smoking? And so it is designed around trying to identify, I would say, performance-related variables in the context of cancer, but we also use the known literature associated with, energy, health, oxygenation, things like that.
And Dr. Warren, I was just going to bounce out of that gentleman into the primary health world, the world of general practice, because as a cancer patient, I know you've had a big focus on that intervention during the acute treatment phase, but there's that terrible moment when your period of treatment is over and you get away from the mothership of the hospital and you're hurled back to the general practitioner in our system, and then you have several years of follow-up, which I'm still in. So really, general practice has to be hand in glove with this strategy, both having the same message but also supporting the ongoing reduction or cessation of smoking. So where does what we call general practice fit in?
Well, so I'm going to ask one quick question and answer that. How many people here are general practitioners?
That's a spooky result.
That's the problem we have in the United States. We have oncology conferences and we don't have general practitioners involved. This is an excellent, outstanding opportunity to engage across cancer care and general practice. General practitioners know how to do cessation support. I don't know how many people in here know how to do it. I can tell you they know really how to do it. They've probably been trying to make it happen for years, and this is an opportunity to connect between these two exceptionally well. And that's one of the things we need to do in oncology, and we're trying to do in the U.S. now, is to reach out to primary care and simple messaging. The message for primary care is, if you think you have a patient with cancer, start the discussion on cessation because it makes a huge difference for their outcome. That's it. After that, they can do the rest of the cessation or what they've been trying to do. Changing the messaging with a clear vision might be a huge, boost to trying to make, these better outcomes realized.
Anyone here from a primary health network? Thank God. So just to help Dr. Warren, well, no, I won't talk. I'm going to come back to that poor young man who's still standing up, but standing is a form of exercise, and incidental exercise helps to keep us alive. Put your hand up if you're from a PHN. So I run to you. Do you want to just quickly stand up and just explain to Dr. Warren what a primary health network is? Won't this be an interesting answer? It's got to be quick. I'll hold the mic.
Sure. Primary health networks in Australia support the work of general practices and primary care services, so to strengthen, support and advocate for primary care services and often the interface with tertiary care services as well.
And so is smoking cessation a main theme in the world of primary health networks?
I think it may be variable. I know our PHN has just commenced a project grant in partnership with the Cancer Institute around smoking cessation in pregnant women. So some definitely do.
Thank you very much. And Dr. Warren, PHNs have buckets of money and they form partnerships with people meant to be targeting health issues within their area, and every bit of Australia is in a different PHN, so important partners. Do you want to introduce yourself?
Hello. Thanks, Graham. Great presentation.
Don't worry, I'm going to put it
I was
close.
told not to be scared of that, by the way. So.
It's for volume purposes and it's a lot less painful than a cannula.
Great presentation, thank you. Paul Grogan from Cancer Council Australia. Just a question on, given the effects of nicotine in compromising cancer therapies, are you cautious about encouraging patients to switch to electronic cigarettes as a strategy?
All right. So in this case, I have to tell you two different things. So I'm the chair or some role on some organizations. So I'm going to give you two answers. One is the organization role and then my response. The organization role, really by and large, we don't have the data. We cannot recommend e-cigarettes for cessation, and technically we can't recommend them for any changes in, whether they're better or worse than smoking in cancer patients. Technically, that's really the position that we're limited to. I know the UK has different positions, so that's the official type of organization opinion. Now, I'm a radiation oncologist, and next week I'm going to be seeing patients who, maybe not next week because most of my clinics have been slowed down by this stupid hurricane, but soon I'm going to see patients again with that issue. And here's what I can tell you. One, I will give nicotine replacement until the cows come home, which means forever in the U.S. I will give nicotine replacement to every single patient who smokes and sleep well at night, and I'm happy. I don't have any problems with nicotine because there's no data that shows that nicotine replacement is bad for cancer patients or treatment outcome. But I know without a doubt smoking is, period. The second part with regards to e-cigarettes, the effects, there's really almost nothing else that I'm aware of that causes a ubiquitous effect on overall mortality, cancer-related mortality, and toxicity as smoking does. It's hard for me to believe, anything else. I don't even know if nutrition does that. It's hard for me to imagine that e-cigarettes would be worse than that. Now, we don't know. It'll take 5 or 10 years for data. When I talk to patients, I say, I don't want you to smoke. I really don't care what you do, just don't smoke. I want you to try and use nicotine replacement therapies or bupropion or Chantix. I'm okay with talking about those things, but use approved medications. Let's get you to start that. If you can't, you don't want to, you're using e-cigarettes and you think you're helping, that they're helping you not smoke, just don't smoke. I don't say, hey, that's going to continue to work. I say, listen, let's just continue to make sure you don't smoke. If you think that's helping, that's fine, just don't smoke. And I know it sounds a little weird, we got to bridge, because right now if I wait 5 or 10 years for the evidence to come out for e-cigarettes, how many of my patients am I going to kill? How many are going to recur, die, have toxicity, because they don't have any guidance behind it, right? So I am wagering a little bit that e-cigarettes will not be as bad as smoking. It'll take a while to get that data back. In the meantime, I know smoking is bad, and I want to prevent that as best I can. Does that help? It's a very tricky type of conversation, but a lot of times I get asked that question.
It's an ongoing discussion, but that's an interesting perspective. Thanks.
Yeah.
Thank you very much. Now, Laura, run over here as quickly as you can. Run to me, you're young. Is there anyone over here with a question or comment?
I do have one comment, by the way, I wanted to offer the crowd. We got to finances and money. Back to this money question. When we talk about paying and supporting and grants and these types of things, for the insurers in the United States, my question is this: why do you want to pay that much money for second-line cancer treatment? Would you rather do cessation instead? You're going to save money if you do that. Why do you want to pay for this extra treatment if you might be able to do something to get around it? And so what I'm getting at is the traditional mechanisms of trying to provide cessation support, usually through grant funding or philanthropy or so forth, the people who pay for cancer treatment are going to be the ones who financially benefit the most because they're not going to have to pay for second, third, fourth, fifth line treatment. So I just want to make sure we're kind of on the same page with that. In very practical terms, the cost savings, you'll have some with patients, The clinical benefits are going to certainly be there for patients. The money is going to benefit the people who pay for the cancer care.
Okay, thank you. We're going to an app question.
I have lots of app questions. Thanks, everyone. Dr. Warren, have you studied cultural barriers to accessing cessation programs? And if yes, what strategies have been put in place to engage those of culturally and linguistically diverse backgrounds?
You know what one of my biggest strengths is ability to say, I don't know. Now, I have a little bit of knowledge of this, but a lot of that I don't know. And what I mean by that is I'm fairly ubiquitous in how I talk to people about smoking, but also cancer care. And I learned an important lesson a couple years ago from a close colleague of mine that showed that in African Americans or black people in the United States, that it wasn't my communication or physician communication, but if they had someone who was an African American, an elderly African American woman say the exact same thing the same way, that the participation was much higher. It completely opened my eyes to the fact that it wasn't my deficit. It was really or anything I was doing right or wrong. It was ignorance on my part about the cultural issues associated with, in this case it was clinical trials design, but it's the same thing for cancer treatment and the same type of thing probably for cessation. I don't have the knowledge for what the cultural influences would be here. I anticipate there are people maybe in the crowd
Yeah, that's
who
what I
know
was just
this
going to
well.
say. Is there someone who feels they can offer a comment in relation to that question because you have some expertise in relation to multicultural people and cessation programs? Anyone like to volunteer? It'd be spooky if no one did. But no more spookier than no GPs. Of course, they are hard-working, self-employed people with staff, and it's usually best to get them at night, which I'm sure all the PHN staff know. Thank you. I'll hold the mic. Do you want to introduce yourself?
I'm Rose Wadwell from Hunter New England Health. I'm Aboriginal.
Can you boost my level, please? It has to be for them to hear. Just trust me.
Okay, trust you.
It's fun watching this, by the way, when she does this. It's cracking me up.
I know. It's confronting, really.
There are many conferences where people can't hear each other. If you speak up, I can pull it back. It's about hearing.
We do a lot of research around how we can deliver smoking cessation in our mob. And what it is, it has to be appropriate engagement and it has to be led by our people because we don't trust. So it can't be people from the cancer centres, it can't be our GPs, it has to have the appropriate teams behind and it has to come from our elders. Our elders are very passionate, so that's how we can close the gap in that in our mobs.
And you're developing lots of Aboriginal materials, specific materials. Can you just tell us a bit about that?
Oh, yes. I've done 3 years ago I did a massive project around the cancer resources for a whole of district and at the moment I'm working on going around a whole of district. So we've got the third largest health district in Australia.
Which one's that?
Hunter New England Health. So it's the size of England. So my role is to develop resources for the whole of district. So I'm going around to about 8 different communities, having yarn-ups around cancer. So we call it women's business and men's business. So we're doing a holistic approach, just not around lungs. So we have breakout sessions and we're delivering that by Aboriginal people. I'm one of the facilitators, and then we break out into the afternoon, we're doing palliative. Well, we've got no uptake in palliative, all very limited. So now we call it finishing up business, and we're hoping to develop resources that we can close that gap as well.
What have you learnt listening to Dr. Warren? What's he got you thinking about?
Oh, a lot. The cost and the survivalship, because most of our people turn up when they're end stage because we're frightened, because we call it a white man's disease. So that's where we're trying to break the gap and understanding. So we're actually educating all our, I think it's about 50 Aboriginal health workers with key messages around early detection and screening. So hopefully we'll close that gap, ensure that all our people get screened regularly, and don't be shame. What we're saying is don't be shame, be game.
And just one last question. I have a bit of land out at Wellington, which is about 5 hours west, and whenever the local Aboriginal community are having any sort of event, there appear to be quit smoking people. They're in shirts, Indigenous shirts about quit smoking. So what's going on?
A lot. We know. We know that 40% of our mob smoke, but some communities it's 80%, and 45% of our women that are pregnant are smoking. So that's one of our core focus in our business plans and our health plans. So there's a lot, and it's, we've got to ensure that it's led by the Aboriginal people with our artwork that's appropriate. And when I say appropriate artwork, it's artwork that's been designed by the community, so it's got to be localised so we can relate to it, and it's all around safety.
Thank you very much. I gave a lot, yes, thank you. I gave a lot of extra time, Dr. Warren, because you can hear in those, tragic figures about proportion of the population smoking. This is one of the most important groups. Is there any other human, before I go to the app, who'd like to ask a quick question or a comment? Please thank you so much, sir. And we'll come to more app questions in the panel, which we'll go to after this question.
Hello, my name is Albert and I work in Prince of Wales. I'm a registered nurse. I used to smoke since I was 14, exactly as you were saying, Dr. Warren. Enjoy your presentation, it was awesome. My question is, why are we not trying to make it harder to purchase cigarettes in America, in Australia, and in any country for that matter? It is just a matter of walk down the road and you can go and buy them. There should be some restrictions made because it's a struggle every day to stay away from cigarettes, even though I've given up for like 2 years. It's the hardest thing to do.
Always a clap when someone talks about giving up. Could I just say, you probably know, sir, that we've got hideous pictures on our cigarettes now, and also they're at point of sale, correct me if I get this wrong, guys, they're behind kind of whited out cupboards. So they are some initiatives, but what would you like to see? What would be better?
I think. Look, I see it as a drug. It is a drug, and I think that you shouldn't be able just to walk to any supermarket, any store to purchase it. I think there should be some control, and and this way at least we could try and get as many people off the habit as possible if we could make it harder for people to buy them.
So I will summarize the reason why in one word: it's money. And so the money that's generated by it still dictates, unfortunately, the distribution, sales, all these types of things. I will say that, and this will probably increasingly come forth, there are some reasonably good changes in developed countries with regards to tobacco use patterns that will probably start coming out shortly. And we're starting to see some shifts. And we go to this e-cigarette question. Tobacco companies are seeing this as well. And so their vision is to transition to things that are not cigarettes to other products. I am exceptionally cautious about this. In 1900, we had almost no lung cancer cases at all. People had to roll their own cigarettes. We had to do some work. It wasn't engineered to be nearly as addictive, didn't deliver chemicals to the brain nearly as fast. It was harsh to try and smoke. You couldn't inhale as deeply. And over the course of the past 100 years, with rolled cigarettes and mass production and menthol and aeration and pH and all these types of things, the addictiveness is outstanding. I don't want tobacco as a addictive consumptive device, but I would love to have something like a cigarette to deliver cancer treatment. I mean, it'd probably be huge and effective and wonderful. But you can't do this with an addictive substance like tobacco, in my opinion. It'll shift. I don't know how long it will take. And unfortunately, the money is the motivation behind it, which drives the politics, legislation, international tobacco control. And I will also say that I know parts of this, but there are people who know far, far more, have their entire careers devoted to that question, the reason why, the policies that help limit tobacco use and those types of things.
I'm going to take one more app question to encourage app engagement, because remember, there's a prize.
All right, how can we overcome this notion that smoking cessation interventions are someone else's job?
So I'm a radiation oncologist, and what I do for patients is I try and treat with radiation to help something better, help them live longer, decrease the chance of tumor coming back, help them feel better. Maybe they don't have pain, maybe open an airway, stop bleeding, I don't know, different types of things. And what it comes down to is that in my career, I'm going to see maybe 5,000 patients, and in reality, I'm probably really going to benefit about 2,500, somewhere between 2,000 and 3,000 if I'm pretty effective. We're a radiation oncologist. There's a concept, and actually medical oncology, surgery, so forth. I didn't ask how many people here were physicians. You don't have to raise your hand.
Well, let's do it. Hand up if you're a doctor, just to get a sense. Thank you. So some.
All right.
Thank you. Welcome.
So this actually may be good. There's something called number needed to treat. How many people do you have to treat to improve one? In the 90s, there was chemotherapy for breast cancer, CMF, this old chemotherapy, been around a long time, it was effective, it did a good job. But AC chemotherapy, which is part of what we do now, it switched. Our entire paradigm shifted to using chemotherapy of a different type, really because there was about a 3 to 4% improvement in overall survival at 8 years. I mean, we focused on 4%. What that means is that the shifting of our care from CMF to AC, one chemotherapy to another, was because if we treated 25 patients, we were going to make one more better. That's number needed to treat. We shifted our entire care paradigm based on we treat 25 patients and we improve one. Smoking, when you look, we're not done with this yet, okay? But I can tell you the range. When you look at the number needed to treat, the lower the number, the better. For a radiation oncologist, in general, a good rule of thumb is that you need a number needed to treat of about 10. Might be 15, but in reality, if you're not going to get a 10% benefit, it's hard to justify the toxicity. For smoking, for survival, recurrence, toxicity, your number needed to treat is between probably 3 and 5. It's probably no higher than 5. Might be a little lower than 3, but you're living at 3 to 5. This is the implications. Let's just go with 5. If you have 5 people that smoke that you didn't get them to quit, you just caused one of those 5 to die, recur, or have toxicity. It's your decision. That's what you're going to see when you don't get someone to quit. The number needed to treat for smoking is astounding. And in this case, I told you earlier I give nicotine replacement when the cows come home. I can do other things and sleep well at night. I can't sleep well at night knowing that every 5 people that smoke, I just left them alone, didn't do anything. Because I know, we have the evidence, we have the data, without a doubt, die, recur, toxicity. At about every 3 to 5 patients, you don't get them to quit, that's what's going to happen to one of them. So the impetus, the motivation for trying to exert this change, decide for yourselves. Is that what you want to hang your hat on when you go home at night? These are the actual, we talk about cost, we talk about phone or in person or nicotine or e-cigarettes or all these other things. This comes down to number needed to treat. Decide if that's what you want to think about when you go to bed at night. Did I miss and cause one of those 5 people to die, recur, have toxicity? That's the reality of where we live with it.
Ladies and gentlemen, would you give Dr. Warren a warm round of applause?